Respected Professor and my dear students, I welcome you all to another session of our sessions on comorbidities and anesthesia. Today we have the sixth session on it, on anemia and anesthesia. Over to Professor and our students. Thank you, sir.
Thank you. We have been going through the comorbidities associated in patients coming for anesthesia. We have covered so far hypertension, diabetes, ischemic heart disease, like that. And anemia is one of the neglected comorbidities, taken very lightly. Am I audible to all of you?
Yes, sir.
Okay. So you just cursorily look at the CBC, and even if the hemoglobin is 8 or 9, you just look at the conjunctiva and say fit for surgery, unless it is a major procedure where you expect or anticipate blood loss. We don't give too much of importance to the fact that anemia. So we have to have a clear concept. Of course, there is a question in theory paper as well as in your practicals. Anemia complicating pregnancy. It's a very common topic. But anemia in the general population, in the non-pregnant population, both men and women coming for major surgery, is not taken so seriously. So we'll just have a quick discussion on that. And because there are exam going students, I have prepared a few OSCE type questions on the anesthesia machine. So I will try to cover this anemia rapid fashion, but touching all the important points. Again, it will be interactive only, and immediately we'll start with the anesthesia machine OSCE also. So that is for your information. I will share the screen. Some time delay in sharing, I don't know why.
Have I try one, sir, from my side?
Yeah, please try, because it's just, is it visible now? No, not it.
It's my screen, sir. I'll stop sharing. Automatically it will come back, sir. Can you try sharing once again, sir? Can you please try sharing once again, sir? Yes, sir. It is visible now.
Okay. Is it visible as a full screen now?
Yes, sir.
Yes,
Okay.
sir. Full screen.
Right. So we'll start with the definition of anemia. How do you define anemia?
Reduction in the hemoglobin concentration less than 13 gram per deciliter, or the hematocrit value below 30% in adults, male, and some 37 in female.
So that is the value for that definition. But what about the RBC? Should the RBC also be or low, or it can be normal?
and
So the actual
of hemoglobin.
So it is the quantitative and qualitative reduction of hemoglobin or circulating red blood cells or both. So you can have a reduction in hemoglobin alone with a normal RBC, or which may not. When will you have a normal RBC count but a reduction in hemoglobin? Which type of anemia? Your hemoglobin will be low, but RBC count will be normal.
Microcytic hypochromic.
Microcytic
Plastosis.
where the hemoglobin content is low, but the RBC count is normal. Okay. So the correct definition for the anemia is it is a quantitative and qualitative reduction of hemoglobin. Why qualitative reduction? What does that adjective qualitative mean? Which hemoglobin you will call it as hemoglobin?
Bounded hemoglobin, sir. Oxygen carrying capacity.
That comes under hemoglobinopathies, isn't it? Thalassemia, sickle cell anemia, all these conditions, the hemoglobin is at fault. You agree? So it may be a general reduction in the quantitative or qualitative and qualitative reduction of hemoglobin or circulating red blood cells, or it may be a defect in both, resulting in the functional status, the decreased oxygen carrying capacity, because hemoglobin's main purpose in the body is to carry oxygen to the tissues. So it should ultimately result in the decrease of oxygen carrying capacity. So that is the definition of anemia. First, this topic I prepared it for anemia in pregnancy. So this is considered as anemia of less than 11 grams in 30 or 33% hematocrit during first trimester, and 10.5 to less than hematocrit of 32 during second trimester. And but in general population, what is that? As Risha said, it is 13 grams. Minimum 13 grams should be there. And I have hematocrit. What is the relationship between hemoglobin and hematocrit?
Hematocrit is 3 times the HP, sir.
Very good. So that is why 13 grams will be equal to 39. What will, supposing the hematocrit is higher than your hemoglobin, what does it mean? Can there be inequality in this proportion between hemoglobin and hematocrit? Normally it is 3 times the hemoglobin. When will the hemoglobin be, hematocrit will be higher than the hemoglobin value? When will it be lower than the hemoglobin value?
High. It will be higher in vitamin B12 deficiency.
Higher in vitamin B12 deficiency. Why? Okay, you tell me the answer later. Okay, so anemia is not a diagnosis but a presentation of an underlying condition. Now, how do you classify anemia? What are all the methods? Is there a single classification or multiple classifications for anemia?
And
So it can be classified in multiple ways. So there is no single classification of anemia. It is based on multiple factors. The first classification is etiology. What is the cause for the anemia? It may be physiological anemia of pregnancy, or it may be acquired causes of anemia, or when the nutrition is not good and you have a chronic infection and there is a hemorrhage, then drugs or cancerous conditions cause bone marrow suppression or chronic kidney disease. All these things are acquired conditions which also can produce anemia. So first classification is based on the etiology as physiological and acquired, and under acquired you have all these causes. Then there can be genetic causes. like sickle cell anemia and thalassemia, they are all genetically determined. So this is the first classification based on the etiology. Any other classification you know? What is first we have discussed etiological classification.
It's from the quantity of the hemoglobin.
Morphology. Second is the morphology of hemoglobin. It can be microcytic when the mean corpuscular volume is less than, what is that FL standing for?
Femtoliter, sir.
Pentaliters. Very good.
Femtoliters.
And conditions are iron deficiency anemia and thalassemia. In these two conditions, the RBCs are very small and their iron content is also low. So you can see this comparative picture between the normal RBC and the microcytic hypochromic, like much more paler RBCs. Here you can see all of them are nicely reddish, whereas here one is almost white in color. So this is hypochromic microcytic anemia. The second is normocytic, and that happens in hemorrhage or hepatic and bone diseases. So this is the normocytic normochromic anemia with effective erythropoiesis still going on. And the macrocytic, where the RBCs become bigger, it happens in B12 and folate deficiency and alcohol abuse. So this is the picture to show you the comparison between the normal RBCs and the megaloblastic RBCs, which have even the nucleus is still present. Large oval RBCs are there. So hyperpigmented neutrophils are seen in between this. This is not RBC, this is a neutrophil with this thing. But the cells are definitely larger than the normal cells. So the second classification is based on the morphology, the appearance. The third classification is based on the ICMR. What is the ICMR classification of anemia? Any idea? It is classified based on the severity of anemia, like mild, moderate, severe, and very severe. Okay, so ICMR has classified that as 4 categories. One is mild, when the hemoglobin reduction is between 10 to 10.9. Moderate anemia is 7 to 9.9. Severe anemia when the hemoglobin is less than 7, and very severe is hemoglobin less than 4 grams. So this is the chart. WHO as well as ICMR both have given this classification based on the hemoglobin value. So this is the third type of classification. So you have to remember 3 classifications based on the etiology. Second is morphology. Third is the severity of reduction of hemoglobin. Now comes the question, how to detect absolute iron deficiency or iron sequestration or inadequate iron stores and inadequate maturative factor deficiency. What are all the tests which will reveal whether it is an absolute iron deficiency anemia or iron is getting sequestrated and deposited in other areas, or there is an inadequate storage of iron, and whether the factors which are responsible for the maturity of RBCs and the hemoglobin, are they deficient?
Serum ferritin level,
Serum iron,
total iron
serum
binding
ferritin,
capacity,
iron binding
Very good.
capacity.
reticulocyte count.
Excellent. So the preoperative anemia, normally for a general population, it is less than 13 grams. For pregnancy, it is much more lower, the values, whereas for the general population, it is considered as less than 13 grams per deciliter. If it is iron deficiency anemia, which is an absolute condition of iron deficiency, the serum ferritin level will be less than 30 nanograms, or ferritin less than nanograms with a saturation of the transferrin less than 20%, or there is an increase in C-reactive protein more than 5 milligrams. What is the importance of this? Why should you check the C-reactive protein when you want to determine whether it is iron deficiency anemia. What does C-reactive protein indicate? When do you test for C-reactive protein?
So it's an acute phase reactant.
Acute phase.
Anemia and chronic diseases.
So there is an acute inflammation or some other infection going on, which will prevent iron absorption, utilization, everything. Okay, so you must, unless you correlate with this, you cannot make sure. That is why this terminology absolute iron deficiency is given instead of simple iron deficiency. So you must always do all these three tests. One is ferritin, you must estimate. Second is transfer in saturation, you must estimate. Third, C-reactive protein. All the three values should have a correlation. Then only you can call it as absolute iron deficiency anemia. Iron sequestration means iron getting deposited in unwanted places. Which condition you will get iron getting deposited in tissues which are not requiring iron?
Chromatosis, sir.
Hemosiderosis or hemochromatosis. Okay, these are the two conditions where iron gets deposited, and that causes some pathology. That causes the dysfunction of the organ. What is bronze diabetes?
Diabetes in a patient with hemochromatosis.
Where? Hemochromatosis or siderosis? What is the difference between hemochromatosis and hemosiderosis? Are they both interchangeable or they are separate conditions? Deposition of iron in the pancreas affecting the function of islet of Langerhans produces a condition mimicking diabetes. Okay, that is called bronze diabetes. And so this iron sequestration, you decide when the ferritin levels are normal, more than 100, transferrin saturation is less than 20, and C-reactive protein also here is elevated. Whereas inadequate storage, the ferritin is the storage form, so there is a lesser than 100 nanograms per ml without anemia. And the maturity factors, vitamin B12 less than 200 picograms or folic acid less than 3 nanograms per ml. All these things indicate the various reasons for the etiology of anemia. So in response, if supposing a person becomes anemic, body does not just watch out and to keep quiet. Oh, he has become anemic. But it tries to help the body to all the tissues to receive the required oxygen level, because the oxygen carrying capacity is reduced. Body somehow wants to compensate and make sure that the aerobic metabolism at the tissue level or cellular level goes on without interruption. So there are some compensatory mechanisms activated in order to restore the supply. What are the compensatory mechanisms you know?
Heart rate increases to increase cardiac output, sir.
Okay. Then is that the first response? Immediate increase in heart rate, cardiac output?
Increase the reticulocyte count to
Reticulocyte count. Can reticulocyte be as effective as a normal RBCs to carry the oxygen and deliver it?
and decrease
The
the
increase in erythropoietin levels.
affinity.
Hmm.
Affinity of oxygen should be decreased too.
So ODC curve shifting, that is also one component, but first and foremost is oxygen extraction. See, when the tissues are, when the oxygen carrying capacity is reduced, the capillary flow remains for a longer time so that the tissues can extract as much as oxygen possible within the circulation time. Okay, so there is an increased oxygen extraction. The second thing is the ODC curve, when it is shifted to the right, the hemoglobin releases the oxygen much more faster compared to the normal hemoglobin. So the tissues are avidly taking the oxygen, and the hemoglobin is ready to deliver or release the oxygen, and there is an increased capillary flow due to reduced viscosity. So these are the basic microcirculatory adaptations that happen in the anemic patients. whatever you said about increase in heart rate, all these things are later. So the first change that will happen is these are the changes, that these three changes you have to remember: increased oxygen extraction, shift in the ODC curve, and increased capillary flow due to reduced viscosity of the blood. Now, which are the organs which are capable of increasing the oxygen extraction from blood?
Heart.
Heart,
Brain, sir.
heart and brain both cannot do that. I will show you in the next question. So increased oxygen extraction, tissues like kidney, skeletal muscle, and skin, they can increase the amount of oxygen they extract. This leads to an increase in total body extraction and a decrease in mixed venous oxygen saturation. So if you take a sample of the mixed venous blood and analyze the oxygen content in that, it will be much reduction. Normally, I told you in the last class, whatever oxygen is being taken, 100% saturation or 100% holding, venous blood returns 75% saturated, isn't it? Last class we saw that there is a 25% uptake by the tissues. Whereas if you see the mixed venous blood of an anemic patient, the venous saturation of oxygen will be only 60%. So 40%, 15% more than the normal person would have been extracted. So these three organs are the tissues. That is why they are able to withstand hypoxemia for a longer time. Okay, but organs which are not capable of extraction, they are the brain and heart, because already they take the maximum extraction even in normal life. So their extracting capacity is saturated fully. So organs that have already a high extraction ratio are unable to compensate, and that is the reason why the brain and heart are getting affected much faster compared to your kidney, skeletal muscle, and skin in anemic patient. Now, what is this graph? What does this graph depict? You see in the x-axis, it gives you the hemoglobin in grams per deciliter, and the y-axis it is cardiac index per value, liters per minute per square meter of the body surface area.
If the hemoglobin decreases, the cardiac index increases, sir.
So effect of anemia on cardiac index. So if you see, if the patient has got a very low hemoglobin, say here 1, 2, 3, 4, of course, survival at these rates will be very, very difficult. But compensation is done by the body to increase the cardiac index as much as possible. When you have a normal cardiac hemoglobin value, the cardiac index becomes, what is the normal value of cardiac index? 2.4 liters per minute per square meter of the body. Okay, normal cardiac index is 2.4 liters per minute per square meter of the body. Okay, so the cardiac index is, you can see, goes on decreasing when your hemoglobin is increasing. So the another compensation done by the body is to increase. That is why I told you there is an increase in capillary flow. So that is how the cardiac index increases to enormous level. And that is why the failure in heart will happen, because the heart works so much more to produce this cardiac index. It fails much more faster if you don't correct the anemia. So are you able to understand this point? As the hemoglobin becomes normal, the cardiac index should become lesser. If the hemoglobin is very low, cardiac index should be high to compensate. Okay, so this is the important thing that you must remember. Another compensatory mechanism that happens is redistribution. This is what I showed you in this, and increase in cardiac output. So anemia causes a decrease in the viscosity of blood, which reduces systemic vascular resistance and increases the cardiac output. And there is a sympathetic activation due to stimulation of chemoreceptor by hypoxemia, which may also contribute to increase in cardiac output. And the cardiac output is redistributed to organs with higher oxygen demand, like brain and heart. That is one of the other things that happen in apart from these three what I told you, and how the mechanism happens in that. The next thing is the altered affinity of hemoglobin. That is the second point what I told you is the shift in ODC curve. Anemia causes a rightward shift because of increase in 2,3-DPG, which in the last class itself we found it is one of the intermediary steps in the glycolytic pathway within the RBCs. So the more the 2,3-DPG formation, lesser will be the affinity of hemoglobin, because this will occupy the hemoglobin sites and release the oxygen much more faster. So reduces the affinity of hemoglobin for oxygen and favors release to the tissue at a higher partial pressure. So these are the initial compensation. Supposing if this primary adaptations in the blood they fail, what will happen? So as soon as the hemoglobin starts decreasing, those three factors I told you about the oxygen extraction ratio increasing, ODC curve shifting, and the capillary flow increasing. These are the three basic immediate compensations that happen in an anemic patient. But if those adaptations are not sufficient to supply oxygen to the mitochondria and maintain aerobic respiration, what will happen? There comes the decrease in oxygen tension triggers a cascade of intracellular adaptations. So what cannot be achieved by alterations in the blood, that shifted to intracellular adaptations, which is orchestrated or affected by what is called hypoxia induced factor. This is a very important concept that you should understand. So because the mitochondria are not able to receive the required amount of oxygen, then there is a hypoxic state there, and there is a factor which is a protein stimulated by this hypoxia, which is called a hypoxia inducible factor, which result in transcription response in the genes, and that is the one which going to stimulate erythropoietin to produce more RBCs, and there is a stimulation of vascular endothelium growth factor, and those that favor movement towards the anaerobic utilization of the glucose. So these three are the intracellular responses if the compensatory mechanisms of the initial phase fails. Now, what are the causes of imbalance between oxygen supply and demand in the perioperative period of the patient? That is intra and post-op. What makes a patient suffer from supply-demand imbalance of oxygen? Reduced
demand.
oxygen delivery. Increased demand is there. Normally, perioperative period demand will increase because patient has undergone a surgery, wound has
Because
to
the
heal.
high
and
increased
he
heart
is
rate,
under-
sympathetic response, pain.
So if there is a reduced oxygen delivery, the supply is reduced. Reduction in cardiac output due to hypovolemia or cardiac depression by drugs like anesthetic agents, that also will reduce the supply. Decrease in oxygen saturation due to lung problems like atelectasis or postoperative pneumonia or thromboembolic event. All these factors are decreasing oxygen supply. Okay, reduction in oxygen delivery, reduction in cardiac output, reduction in saturation, and further reduction in hemoglobin as a consequence of blood loss during surgery or inhibition of erythropoiesis by altered cytokines. And if the hemoglobin becomes more attached to oxygen, the affinity increases with the ODC curve shifting to the left, which happens in hypothermia. That is the reason why we take so much of care to keep the warmth and the temperature of the patient normal by using warming blankets and warm IV fluids, and in the post-op we use the radiant warmers. All these things are mainly done to prevent hypothermia, which will cause the ODC curve to shift towards the left, which will cause decreased release of oxygen and increased oxygen requirement. So all these factors reduce oxygen delivery, reduction in cardiac output, decrease in oxygen saturation, reduction in hemoglobin, hypothermia. All these things cause a reduction in the oxygen supply. But the demand is increased because patient undergoes a surgery, and if he has inadequate pain relief, or if he develops postoperative fever, or if he has shivering in the postoperative phase, or there is a lot of stress response, all these things increase the demand. So unless you match the demand, again patient will suffer from inadequate oxygen supply. Okay, so this is the balance that is going to happen in the perioperative period. What are the common causes of anemia in the perioperative period? All of you know that it can be because of surgical cause. The most common cause is the perioperative chronic period or a chronic blood loss, nutritional deficiencies, and the anemia of chronic diseases. Okay, and how to start to assess an anemic patient. Supposing you find the hemoglobin is only 9 grams or 8 grams in a patient who has come for pre-anesthetic checkup. Will you accept and give him fitness, or will you want to work out and find out why he is anemic? In case you want to find out the reason for his anemia, how will you start the workup?
First, we have to take
Sir,
history
we
regarding
can
the
go
First,
daily
assess the
iron
bone
intake
marrow
or any
response
weight
to
loss.
anemia by measuring the reticulocyte count. So, which most of us we do not do. We just see a hemoglobin 9 grams, you say patient is anemic, unfit, improve the hemoglobin and send for review. That is the common comment we will write and send back. But if a physician is good enough, he should find out the reason for anemia, for which you have to first assess the reticulocyte count. A low reticulocyte count indicates a poor bone marrow itself is not able to produce the reticulocyte, which will further be classified as on the basis of mean corpuscular volume as morphological micro, normo, or macrocytic. And the most common causes of microcytic anemia is iron deficiency. So the majority of the preoperative anemic patients will fall into this category of iron deficiency anemia, which can be confirmed by low ferritin level and low saturation of transferrin. So the first 3 investigations you should ask for in a patient with anemia are: 1 is reticulocyte count, 2 ferritin levels, 3 saturation of transferrin level. If you do these 3 things, you can pick up the reason for the anemia very easily. If all these values are normal, it is mainly due to acute blood loss. It is not due to any other problem. So what are the causes of normocytic anemia? Here the causes are maybe kidney or liver disease. Anemia of chronic diseases usually characterized by high ferritin level and inflammatory markers, and it may be a dimorphic anemia, the combined iron and B12 folate. So it may be macrocytic or normomacrocytic anemia, and early iron and B12 deficiencies or acute blood loss or myelodysplasia. So these are all the causes of normocytic. RBCs are looking normal, but the RBC count and hemoglobin values are low. Then you call it as a normocytic normochromic anemia. Then what are the causes of macrocytic anemia? All of you know why macrocytosis or megaloblastic anemia occurs. It is mainly because of
B12
B12 and
deficiency
folate
and
deficiency.
folic acid.
So it is classified as megaloblastic or non-megaloblastic depending upon whether or not megaloblasts are present on peripheral smear. So megaloblastic anemia is caused by folate and B12 deficiency, and also by some anticonvulsant drugs. If a patient has been on carbamazepine and sodium valproate for a long time, they can develop this megaloblastic anemia, or they may be on cytostatic medications. And non-megaloblastic macrocytic anemia can be related to alcohol abuse or thyroid and liver diseases. So these etiological factors you should be aware of. What are the hemoglobin independent effects of iron? This is all the while we know that we have been talking only about iron deficiency anemia and the requirement of iron for maintaining a normal hemoglobin status. This question is asking you whether you are aware of any functions which are dependent on the iron intake, which is called non-hemoglobin or hemoglobin independent requirements for iron. Is iron required only to make hemoglobin, or is there a role for iron in any other functions in the body?
Like electron transport
After
chain.
ulcers,
Electron transport chain, very good. First and foremost, enzymes. Okay, so there are several things. This is the function of hepcidin. Before that, I think the flow chart. So this question I think is wrongly printed in the other side. So what are the hemoglobin independent effects of iron? Iron is essential for many physiological processes such as cell growth, right from the growing age. That is why we must have proper iron intake in our food all the time, right in the growing stages itself. So cell growth and differentiation, neurotransmission, host defense and cardiopulmonary function are all dependent on iron. Many cellular proteins require iron to function. Examples are mitochondrial electron transport chain proteins and enzymes like involved in the DNA metabolism, like DNA primase and DNA helicase. They bind to iron. So enzyme activity is dependent on iron. And another enzyme ATPase ABC1, which is needed for messenger RNA transmission, also binds iron. Iron also plays a critical role in the oxygen sensing part of hypoxia inducible factor. This is what I told you, which triggers the earlier changes or the reactions that happen in the intracellular level, like erythropoiesis stimulation, vascular endothelial growth factor stimulation, all these things. So for that hypoxic inducible factor to be doing its role as an oxygen sensing agent, iron is very important. And degrading of hypoxia inducible factor by the enzyme prolyl hydroxylases is dependent both on iron and oxygen. And in studies, it shows that if iron is depleted or there is a reduced iron level, there is a increased pulmonary hypertensive response to hypoxia. Hypoxic pulmonary vasoconstrictor response is more severe in patients with anemia. That is another reason why these patients develop failure of the right ventricle also, because anemia causes an increased or exaggerated response to hypoxia, which is a normal pulmonary vasoconstrictor reflex, is a normal reflex as you all know. But when it gets exaggerated, it will result in pulmonary hypertension. So that may cause a right ventricular strain. So iron loading attenuates this response. So that is another reason why you should correct your anemia in the preoperative phase. And iron is also essential for immunity. And both iron deficiency and iron overload are associated with increased risk of infection. So you should have neither too low in iron, or you should not have hemosiderosis or hemochromatosis. So both will cause the suppression of immunity and make the patient more susceptible for opportunistic infections. And in addition, low hemoglobin impairs the adaptive immune response of the T and B cells. So if a person develops infection, normally we have a humoral and cellular responses of immunity, which will take care of the infection. For that, we require the T cells and B cells. So that activity of the T cells and B cells also will be impaired. So you will not get the desired immunity response when you are exposed to an infection. or you will not develop adequate antibodies when you are exposed to a vaccination. So from all these angles, iron becomes a very, very important component in our food, more than just being part of the hemoglobin. Okay, so that is another reason why if a patient is anemic, his wound gets infected, or the post-operatively he develops some other infection like pneumonia or urinary tract infection. All these things happen because of the above said reasons that you happen. So once again, we'll go back to the original slide. And so what is the function of hepcidin? What is hepcidin, first of all?
It's a hormone secreted from liver, which inhibits
Liver,
the absorption
for what?
of iron. To inhibit the
What is
absorption of iron from small intestine.
very good. Not only iron from small intestine, but also it helps in the macrophage uptake of from the resistant RBCs. When the hemoglobin is released from the old RBCs which have completed their lifespan of 120 days, this hepcidin only helps in the macrophages taking up the red blood cells and then releasing the hemoglobin to plasma. And it also controls the duodenal absorption of iron. So there are two functions. Hepcidin is an iron control hormone, blocks dietary iron absorption and iron recycling through macrophages. So it has got these two functions, and this also is as an indicator of the anemia. It's also nowadays taken as a marker to find out whether there is a anemia. And this is the flow chart all of you should remember. So if a patient is anemic, first thing you do, find out the reticulocyte count, whether it is a low reticulocyte or a high reticulocyte count or a normal reticulocyte. If it is low reticulocyte, look whether it is for microcytic, normocytic or macrocytic. If it is microcytic and normocytic, immediately ask for ferritin, transferrin saturation, CRP, urea and electrolytes, because it may be because of kidney disease also. So the four investigations you should ask for: ferritin, transferrin saturation, CRP, urea and electrolytes. If it is going between normo and macrocytic, ask for vitamin B12, folate estimation and liver function test to rule out any reason because of alcohol abuse and liver diseases. Okay, so this is the way you should go for the investigation. Ask for reticulocyte count first. Low reticulocyte with normal or microcytic for estimations: ferritin, transferrin saturation, inflammatory markers like CRP, urea and electrolytes. If it is on the higher side, bigger size cells, macrocytic, vitamin B12, folate and LFT. And then if it is microcytic, iron deficiency anemia. If it is normocytic, it may be renal anemia, anemia of chronic disease or dimorphic anemia. If it is macrocytic, vitamin deficiency, thyroid disease, alcohol abuse and liver disease. So it is very easy to find out the etiology by using this flow chart. And if it is a high reticulocyte count, maybe because of LDH, serum iron, these are the investigations you have to do: LDH level, serum iron, free plasma hemoglobin and haptoglobin. And it may be causing non-hemolysis or hemolytic type of anemia. So these are the things. In this way you have to go for further investigations. Now coming to the clinical aspect of it, so far we have seen some important points which are not commonly discussed. That's what I wanted to impress on you. These points which are not commonly taught in the textbooks and the classical teachings. So extra points what you have to learn. Now coming to the clinical judgment, when your patient is given to you who is anemic, what are the points in the history you should first elicit? What questions you will ask the patient?
Fatigue, dyspnea on exertion.
So first thing we should ask questions related to the finding out the etiology, isn't it? Patient says he is because of some complaints he will have, So any history of bleeding, that is in the female during the menses and pregnancy, any history of exertional dyspnea, palpitation, paroxysmal nocturnal dyspnea, pedal edema or giddiness, and history of bleeding or leaking PV, whether there is a, even though I have given it as a negative, you must ask whether you have a bleeding PR or melena. This is a very, very important question, which many patients may not have noticed. So how will you know, what question you will ask the patient about, find out the presence of melena?
Color of
If it,
stools.
color, it will be what color?
Black color.
Black tarry
Like
stools.
tarry
Tar.
stools. Okay, so it is tar like, very severely black. But if it is a frank PR bleeding, that is rectal bleeding, like in piles, patient will know. And what is the characteristic of bleeding in a piles patient? Will it come along with the motion or before the motion or after the motion?
Prior to motion pass.
Eh? It's called flash in the pan. Usually it
Along with
happens
the
after
motion,
the
sir.
patient has passed the motion, the bleeding, because there is an erosion while the motion is coming in the bile mass. And because of the pressure by the solid motion, the bleeding does not occur at the time. After the stool is evacuated, especially these patients have chronically constipated. So they have a very hard stool. So they try to push it by straining. At the time, the bile mass which is traumatized will not bleed because the hard mass of fecal matter will be pressing on it. Once the fecal matter drops onto the potty, then the bile mass will start bleeding and it will occur like a splash. So it is called the splash in the pan type of bleeding, which is very characteristic of bleeding per rectum in hemorrhoids or bile mass. Okay. So no history of fever or chills, burning menstruation to find out renal or urethric infection. History of cough with expectoration to rule out tuberculosis. History of drug intake, anti-malarial, aspirin or even anticonvulsants. And whether any jaundice, history of discoloration and sclera, whether any comorbidities like diabetes, hypertension. So even though I have put no, most of the time it will be positive for either this or this, or it will be drug intake. So you must ask all these questions to find out the cause from the patient. Now, what are the signs and symptoms? This is for eliciting the etiology. Next, you must ask to ascertain whether it is the anemia, which is the pathology in the patient. What signs and symptoms these patients will have? What will be the early feature of anemia in a patient who was quite normal earlier? What is the first symptom they develop?
Dyspnea and exertion and fatigue.
Before that, tiredness and weakness, because the cells are not receiving adequate oxygen. The oxygen carrying capacity is not normal. So early hypoxemia, they feel very exhausted and tired in their day-to-day activity itself. Later on only they start feeling the shortness of breath, and they have a pale or yellowish skin. They may have irregular heartbeats. They may have dizziness and lightheadedness, chest pain, cold hands and feet, and headache. So these are all the signs and symptoms which you should ask for. Now, once you make a diagnosis of anemia from the history and the clinical symptoms, what investigations you should order?
Reticulocyte
Complete
count
blood
with a
count.
peripheral smear.
Complete
So
blood
we
count.
just know, sir,
and it-
what are all the tests we have to do to find out the cause, I mean, the degree and severity of anemia and the etiology of anemia. But if the patient is coming for surgery, we have to first do all the routine investigations like CBC, coagulation profile, CXR, EKG, echo, etc., RFT, LFT. And specific tests for iron deficiency anemia are serum ferritin, transferrin saturation, and there is something called reticulocyte hemoglobin content. that also to be checked, and CRP and hepcidin level. These are the 5 tests recommended for iron deficiency anemia to assess the severity and degree of anemia. And total iron binding capacity is also quite important to find out the type of anemia. Now, these are all plans made out for pregnancy in anemia. Adaptations already we have talked about, and so now iron homeostasis. Sometimes the examiners are fond of asking question on iron homeostasis, especially if you get a case on anemia complicating pregnancy. This is a very repeatedly asked question in the viva. So how does iron enter our body and how is it utilized and what is the mode of transport? These are all the things that you are expected to answer. Do you have any idea about this? Right. So this picture will tell you what are the things that are happening.
Transported
with regard-
across the mucosal cell and carried by the transferrin.
So the
Oxidized from ferrous form to ferric form. That's it.
so iron mainly we get it from our oral diet. Okay. No, nobody takes iron injection or IV iron every day. So the main source of iron is our dietary source. So what are all the dietary constituents which are rich in iron?
Leafy vegetables.
Leafy vegetables, very good.
Dates, amla,
Amla,
red meat.
very good. Okay, excellent. So these are all the normal dietary supplements which will help you to get more iron. So they are absorbed from the small intestine, okay, and then taken to iron in the plasma goes to the, where does it go? So there is also absorption from the gut as well as from the old RBCs which are broken down, and that release also contributes to the iron in the blood. So the two sources are the absorbed iron from the intestines and the iron release from the old RBCs or senescent RBCs, which contributes to the plasma iron level, and then it goes to the liver and stored there and then released whenever required for erythropoiesis and bone marrow. And this is the whole process of iron hemostasis. And in the liver, the hepcidin, the iron, the hormone which is produced in the liver, that is the one which is controlling the absorption as well as the other picture what we saw, to maintain the normal iron level so that we don't get excess iron in the plasma which will be unnecessarily deposited in unwanted tissues. Okay, so these two pictures will tell you about the iron and the hematological parameters which have to be checked in an anemic patient are hemoglobin, serum iron, red blood cell count, then all the details about the RBCs like MCV, PCV, hematocrit, MCH, MCHC, PABC, transferrin, all these investigations are required to make a detailed investigation of any anemic patient. But from the examination and the anesthesia point of view, unless the patient is grossly anemic, we normally don't do all the investigations, but we stop with the ferritin and transferrin and CRP levels. And the laboratory values with their normal level, and because the adaptations in anemic mother, all these things are happening in all the patients, not only in the anemia in pregnancy, but it will happen in all anemic patients. There will be an increase in the secondary response after the initial response of extraction of oxygen, ODC curve shift and increased capillary flow. These are all the cardiac compensations that happen in increased output cardiac output, decrease viscosity, increase in 2,3 G principle, erythropoietin. And there was a question asked in the book before you come, what is the transfusion trigger? So when the hemoglobin is more than 10 grams per deciliter, there is no need for transfusion in any patient undergoing or waiting for surgery. If it is less than 6 grams, you must transfuse and correct that anemia before that. In between, you have to decide by clinical correlation. What are the clinical correlations you will look in? Supposing a patient has got 8 grams hemoglobin and he is waiting for a hernia surgery. How will you decide whether you can accept him for surgery or not?
If it is nutritional, we can add on the supplements.
No. Supposing the HP value is given as 8 grams per deciliter and he is coming for inguinal hernia repair. So what are the criteria by which you will accept or reject the patient?
If it is symptomatic, he's having, if he's symptomatic, having dyspnea.
So if he is able to compensate and manage his day-to-day activities like climbing a flight of stairs, metabolic mets you have to assess. First, an effort tolerance. If the patient is comfortable without dyspnea or no features of failure, no fetal edema, and he is not extremely exhausted or tired, that means he is a well compensated patient at 8 grams. And the surgery inguinal hernia, you don't expect more than 50 to 100 ml of blood unless your surgeon purposely cuts the femoral artery. Okay, so there is no reason why he should bleed unnecessarily. So you can easily accept and say okay for that patient. You need not be very strict and say, no, you bring your hemoglobin to 12 grams, then only I will treat you. I will take you for surgery. So that is the way you do the clinical correlation. On the contrary, even if a 10 grams patient comes with a history of breathlessness even for day-to-day activity, then you say you better correct your anemia and come even if it is inguinal hernia surgery. Okay, so it is based on the clinical adaptability that the patient has developed and the nature of surgery. These are the two criteria by which you will be able to decide whether you can give fitness for a patient or not. Okay. So this is how the patient, how anemia affects is because it is decreasing the oxygen carrying capacity, and normally this question is also asked, what is the amount of oxygen carried by the blood? So the formula all of you should remember, hemoglobin multiplied by 1.34 into saturation is the first part. The second part is the dissolved portion, 003.003 into oxygen tension. So if you add these two, you will be usually getting around 20 to 21 ml per 100 liters. That will be the value for a normal hemoglobin person. Okay, so that is how the calculation is done, and these are all the various ODC curves. This discussion also can come in the examination. So what happens if the ODC curve is shifted to the right and left? We will not waste time on that. And of course, these are all the clinical signs and symptoms in anemic patients. And history taking, these are all the things that you have to take. And investigations, for special investigations, again, we have seen all that. And risk period in pregnancy, of course. And the important, another basic thing you must remember about the erythropoiesis. Why you have to know about erythropoiesis when you are dealing with a patient with anemia? Okay, so RBC production and maturation is very important. The RBCs are produced from pluripotent hemopoietic cells. Which organ in our body is produced by a unipotent hemopoietic cell? And what is its importance? Which organ in our body is produced by unipotent, that is a single hematopoietic cells which produces only that cells which is going to form that organ. That's called a unipotent hemopoietic cells. or hematopoietic cells? Any idea? Liver. Liver is the only organ which has got a unipotent hematopoietic cells. And that is the reason why if you transplant a small portion of the liver, it regenerates so fast. Within 72 hours, you will find that the small portion or one lobe of the liver which has been transplanted into the recipient will grow and become the normal size. Okay, so that is the beauty of a unipotent cell. Whereas pluripotent cells, they produce not only RBCs, WBCs, megaloblasts, all those cells are produced. That is why it is called the pluripotent hematopoietic cell. From there you get what is called the proerythroblast, and then it becomes erythroblast, and then it becomes reticulocyte, and then becomes erythrocytes. So 4 stages are there: proerythroblast, erythroblast, reticulocyte, and erythrocyte. Now, what is the main difference you are seeing in this picture by visualizing this slide?
Absence of nucleus.
Loss of nucleus.
At what stage the nucleus is loses? From the erythroblast to reticulocyte. So once it becomes the reticulocyte and an erythrocyte, there is no nucleus. And what is the importance of absence of nucleus?
Increase surface area.
This is the answer. Because they don't have nucleus, their lifespan is only 120 days. Whereas cells which have a nucleus, they can live longer. Okay? And another importance, why there is a nucleus at this level and then after that it disappears. So what is the importance of having a normal or a good nucleus in this level, proerythroblast and also normoblast? The answer is here, because the hemoglobin synthesis starts at the basophilic erythroblast, okay, and then goes into polychromatic erythroblast and orthochromatic erythroblast. So when the nucleus is there, then only it can synthesize the hemoglobin. And once all the hemoglobin is synthesized, it becomes reticulocyte. So that is the reason why we check the hemoglobin level in the reticulocyte also. The other slide I showed you, one of the investigations we have to do is the find out the content of hemoglobin in the reticulocyte. So at this level itself, it is low. That means it is one of the indicator of iron deficiency. So it is not able to have a normal hemoglobin. Then it becomes a erythrocyte. So the 2 points that you have to remember with regard to RBC production is, in the first 2 stages, there is a nucleus present, and that is responsible for synthesis of hemoglobin. And once it reaches the stage of reticulocyte and erythrocyte, the nucleus disappears and the hemoglobin is already incorporated into the cells, and that is the final stage. It cannot increase the hemoglobin anymore. Okay, so that is the importance of this erythropoiesis. And the stages of involved in iron deficiency anemia are there are storage iron, transport iron, and erythron iron. There are the 3 factors. So if there is an excess load, or it can be a normal, or it can be an iron depletion in the form of lack of storage, or iron deficient erythropoiesis, or iron deficiency anemia. In all these things, the storage iron becomes completely reduced. And in the iron deficiency anemia, the erythron, that is the iron in the hemoglobin, also is low. So you find this is a less red and it becomes pale. So you get the microcytic, microchromic, and microchromic anemia. So these are the changes which see in the picture. And what is the iron requirement per day? This is another important question. 800 to 1000 milligram is required, and early pregnancy you require 2.5, and 20 as the mother weeks of gestation increase, the iron requirement also gradually increases, because the growing fetus also requires the iron. So you have to increase the iron intake as the fetus grows. And sequential phases of how hemoglobin deficiency occurs is decrease in storage, decrease in iron erythropoiesis, decrease in peripheral hemoglobin, and decrease in tissue oxygenation. So these are all the sequence of events that will happen in iron deficiency. And why iron deficiency is more common? Because of the low dietary intake and chronic intestinal diseases like amoebiasis, malaria, chronic blood loss, and too frequent pregnancies are all reasons for iron deficiency anemia. So iron absorption and transport. This is also another common question in the examination. So you take iron with your food. So iron in the food goes to the lumen of the GIT. Hydrochloric acid is there, and it is the ferric ion. Fe3 plus is ferric form, and ascorbic acid and cysteine are required to convert this into ferrous form, that is Fe2 plus, and it will be absorbed only in the ferrous form, and it will go to the mucosal cells. It does not directly enter the blood. So it is first of all entering the cells lining the GIT, and there it is again converted to ferric form, Fe3, and combined with a protein called apoferritin and stored as ferritin. Okay, so ferric ion plus apoferritin produces ferritin, which is a storage form, and the conversion of here the ferrous to ferric is done by an enzyme called ferrooxidase. And once it is stored in ferritin form, whenever there is a requirement or a decrease in the plasma ferritin or iron level, then the stored ferritin will be again reverted back to ferrous form by an enzyme called ferroreductase. So ferrooxidase converts Fe2 to Fe3, ferroreductase converts Fe3 to Fe2, and so please remember Fe2 is the form which can come across a cell membrane. Fe3 cannot move out of a cell or cross a cell membrane. Only the ferrous form can get transferred from the gut lumen to the cell, from the cell to the plasma. It is only the ferrous form. But the storage form, it has to be converted to ferric. So once it goes to the plasma, again it is converted back to ferric, and again combined with some apotransferrin. Here it is apoferritin, here it is apotransferrin. So it is called the transferrin ion, which is stored either in the liver, again as ferritin and hemosiderin, or taken directly to bone marrow, muscle, and other tissues. So the transferrin, which transports the iron, takes it to liver as well as bone marrow, muscle, and other tissues. So this is the simple iron absorption and its transfer, which may be asked in the theory examination for the juniors who are waiting for their exam and to appear theory, as well as for senior students appearing for practical exam. Okay? And these are again on the form given in the written form. So factors which affect the absorption of iron are ferrous form is absorbed, ferric form not absorbed in human body. So acidity, hydrochloric acid, vitamin C, cysteine, SS group proteins are all facilitating factors. That is why you are not supposed to drink or eat anything. You will have to have a lot of HCl available in the stomach, which is absorbed easily. So usually you have to take it just before your food. And administration of alkali decreases iron absorption. Calcium, copper, zinc lead to inhibition again. And phytic acid found in cereals, oxalic acid, they also decrease or interfere with iron absorption. Small peptides favor iron uptake. Deficiency of anemia iron absorption increase 2 to 10 times than normal. So when a patient becomes anemic, nature makes it that you absorb more iron. That is why we prefer oral iron therapy all the time, because the absorption will be quite good. High phosphate dietary content decreases iron absorption, and copper deficiency is also iron deficiency is diminished, and so you can add a little bit of copper and not excessive copper. Tea and eggs decrease absorption. Impaired iron absorption in malabsorption syndrome also will happen, and partial and total surgical removal of stomach. So that is one of the reasons after bariatric surgery, patients can become anemic because of the reduction in the surgical removal of the stomach or intestine. And the factors regulating are duodenum and jejunum is the site of absorption. Regulation at the level of absorption by the mucosal block. So adequate iron quantity storage and absorption will be automatically decreased. That is controlled by hepcidin. Iron stores depleted, absorption will be increased. And receptor mediated uptake is more in iron deficient state. In iron excess, receptors not produced, so it will not be absorbed. And body iron regulation by hepcidin, how it is happen, these are all the mechanisms. And iron excretion from human body, it is one-way element. Hemostasis and absorption levels, menstrual cycle, bleeding, pregnancy, bleeding piles, pathological conditions, and unabsorbed iron or desquamated cells also help in excretion iron in the feces. And lesions in the urinary tract, excretion of urine and the iron in the urine also can happen through the urinary tract also. Now, modalities of treatment are oral iron, parenteral iron, and blood transfusion. These are the three methods by which we can rectify the anemic state of the patient. So, parenteral iron, you have injectable iron, or you can stimulate patient's own erythropoiesis by giving human recombinant erythropoietin. So, oral iron therapy, sometimes they ask you this question, you require 100 milligram per day, and then it raises hemoglobin 0.8 grams per deciliter per week. So these are the preparations which are available: ferrous gluconate, fumarate, succinate, sulfate, etc. All ferrous forms. Remember that. So Fe2 forms absorbed, and then side effects it can usually produces the GI upset, and patients may not comply with the because of this problem. They get a GI upset, they may not like to continue with the medication. And worm infestations also prevent the absorption, so make it ineffective. So first deworming should be done, and then only you must give iron orally. And these are all the various tablet forms with their content in the hemoglobin and the amount of elemental iron present in that. And what are all the indicators of iron therapy? Increase in reticulocyte count, increases 3 to 5 days after initiation of therapy. This is the response. How you find that your patient is improving after iron therapy is increase in HP level, epithelial cell changes, especially tongue and nail revert back to normal, and hemoglobin reverses normal after 6 weeks of therapy. Okay. And myths about oral therapy is slow release preparations are well tolerated. No, it is not correct. Hemoglobin preparations, better bioavailability. So all these points, of course, not needed for now. And parenteral iron sucrose, because sometimes the examiners may ask you, even if you get a non-pregnant patient, if they are anemic and they require a major surgery, how do you correct the anemia? That also can be asked. So better to remember iron sucrose is a preparation that is usually available, and iron sorbitol citric acid complexes, and dextran iron combination, which is Inferon, which is an intramuscular iron. It is given as 0.5 ml, testos to be given, then 75 to 100 milligram per day is given. And there is a separate technique for injecting this Inferon, because otherwise it will leak out through the injection site and stain the skin and the clothes of the patient. So you adopt what is called the Z technique, where you pull the skin and fat and put the needle here and then deposit the drug and then leave that, so that the hole moves away from the needle port moves away and the drug stays in the deeper tissues. So it should be injected into the muscle. It should not be injected. Iron preparation should not be injected subcutaneously. So you must have a long needle and go through the subcutaneous into the muscle and then only inject it by pulling the skin and subcutaneous like this, so that you can see this white, this thing is the track of the needle. So that should go away from that, so that drug does not leak out. And intravenous iron, of course, these are all the things. How much the complications are thrombophlebitis at the IV site, and systemic malaise, fever, arthralgia, urticaria. Even anaphylactic reactions have been reported after iron injection. So test dose is very, very important. And what are the indications for blood transfusion? So majority of the cases of anemia in the preoperative phase can be treated with oral preparations mostly. If not responding or not tolerating oral, go for parenteral iron. If that is also not suited, then you correct it. Or if you don't have the time to wait to correct the anemia and you require a faster surgery, then you have to resort to blood transfusion. So it is not should be a routine. Most of the hospitals now, we find that patients having low hemoglobin, immediately they give 2 Paxils transfusion the same day. That should not be the way. It should be treated according to the availability of time with either oral or parenteral, and the blood transfusion should be the last resort, because they found that patients who receive blood transfusion and come for surgery have more morbidity and mortality. So here anemia first seen after so I'm sorry. So what are the adverse reactions of transfusion? It can produce transfusion reaction, volume overload, etc. And WHO states transfusion should be prescribed only for conditions where no other treatment is helpful. Okay, this guidance is suitable for all patients, not only for pregnant mothers but also for other patients who are anemic. This is the role of folic acid and vitamin B12. I'll just rush through this. So you can see these are all the foods which are able to give that. You have vitamin B12 rich foods like fish, crab, cheese, chicken, eggs, red meat, milk, and almonds. And for foods in folate, you have leafy green vegetable, asparagus, broccoli, and Brussels sprouts, seeds and nuts, avocado. All these things are good in. Even our vendaka, okra is good for folate. Cauliflower, beef, and bell pepper. All these things are good in supply of folate. And types and forms of folate, we will not go into that. Management of labor, not go. A few words about sickle cell anemia and thalassemia, which are also causes of anemia, which we saw in the first slide as etiological factors, genetic factors. So these patients have a mutations in the amino acid series in the DNA and RNA, resulting in mutant protein produced. So glutamine is replaced by valine, and so the hemoglobin, the RBCs are not, gets polymerized. The hemoglobin gets polymerized very easily, and it loses the shape and becomes a sickle shape. So most of the things is the hemoglobin is of not of good. That is why the qualitative reduction in the hemoglobin. The first definition we saw happens here because of this change. And factors causing the sickling or hypoxemia, the hemoglobin, 50% hemoglobin sickle cells present, dehydration, hypotension, hypothermia, and acidosis. And of course, we will not go through all this. Thalassemia is another hemoglobinopathy where the chromosome 11 is defective, and this causes either absence or mutation in the globin chain. Mostly that is the problem here, and this can lead to increased iron loading. So these patients may have more of the iron deposition or sequestration in unwanted areas, and they can withstand both RA and GA. And the COVID infection during IDA pregnancy are all not required. So that finishes our discussion on anemia and pregnancy. So to recall or recap the whole topic in a formative way, first you know the definition, then you know what are all the etiological causes for anemia, divided into etiology, morphology, and the ICMR and WHO classification. Then you have to know what are all the adaptive mechanisms body produces to withstand the anemia before you start treating it. Early adaptations and late adaptations, cellular adaptations especially, which are not commonly taught or dealt with, like increase in erythropoietin, vascular growth, endothelial growth factor production, and the ability to utilize glucose in the anaerobic way. All these things are done by the hypoxia inducible factor. That is one word that commonly not very well, very frequently taught to students. So remember that hypoxia inducible factor is one. And you must know what is the importance of iron for other functions in the body. Then you go on to see what is the role of hepcidin and other control mechanisms, and the flow chart, importance of investigations to determine the severity of iron deficiency or the anemia, namely the ferritin level, the transferrin saturation, the CRP level, then the iron binding capacity, and hepcidin level, and of course the so 6 point what is that? Reticulocyte hemoglobin content. Okay, so these are all the investigations that have to be done, and later on, how clinically, how you take the history, what are all the clinical symptoms and signs, how do you affect the various systems, and how you have to. Once again, just hold on, I will come back. One of my brother has come and he is not well. So sorry. So shall we go on to the Nagaswamy?
Yes, sir. Yes, sir.
Are you able to hear me?
Just yes.